Hey everybody, welcome to Coffee and Cases, the December edition. We're so glad that you are here. This month is Viewer's Choice, so we are going to be talking about stroke in young people or young stroke. And you know what? I'm almost not a young stroke anymore. I'm almost, if I was to have a stroke, I'd be an old stroke. So geriatric. So that is something I've just had to come to terms with, but I think I'm getting there. Anyway, we're so happy to have you guys with me today. Well, so I'm Ruth. I'm a stroke nurse here at RUH and also kind of work provincially in the stroke system. So I've been out and about to lots of all of the stroke centers actually in the province, save Lloydminster and Cala. I think you're our Lloydminster connection. And I'm sorry we didn't get together today, but next week we will chat. Also with me, of course, Brett, not my sidekick, not my wingman, my partner in crime. And then we have our producer, Ashley, stroke prevention nurse, and she helps us out with all the kind of logistics of Coffee and Cases. So before we start, I just like to do a land acknowledgement. So while we meet here today on a virtual platform, I'd like to acknowledge the Indigenous peoples of the lands that we are on today and take a moment to acknowledge the importance of the lands which we each call home. As we gather here today, we pay our respects to the First Nations and Métis ancestors and reaffirm our relationship with one another. And again, the purpose of our virtual rounds is to chat about kind of pertinent topics throughout the continuum of stroke care. And just as a reminder, well, actually we're on Webex, so it is quite secure, but we're going to keep our, our cases like high level and no patient or health information can be shared. And really our cases are to provide for general information and general conversation around it. And we appreciate that this is a huge community of a lot of experts. So please feel free to jump onto the chat and talk to us. If you have something you want to share your expertise about, we would love to hear from you. And yeah, I think that's it. Okay, so without further ado, I would like to introduce our first guest speaker, and his name is Dr. Brett Graham, and here's the bio that Brett provided. So Brett Graham is a stroke neurologist in Saskatoon. He has 3 children who he drives to various activities in the evenings. If he had free time, he would read more books and play more disc golf. And that's it.
That pretty much sums it up.
That sums up Brett Graham. So let's start sharing our slides here.
You see it? Okay.
And we'll jump into nope. Sorry, guys. I'm sharing the wrong screen. 1 second. I want to share. There we go. See if this will work. Oh, sorry, Brett.
Give it away. All
Close your eyes, everybody. Okay, sorry, Brett.
Yes, do you guys see the screen? Yeah. Can I get a thumbs up? Oh, that was Ruth.
Oh, shoot. Oh my gosh, what happened there? Sorry, you guys. We are glitching out like nobody's business. Oh my goodness. It is not a Christmas miracle around here, I'll tell you that.
It's going to be worth the wait, though.
It's going to be worth it.
Yeah.
I have to confess,
Alright.
this is my first coffee in cases, and I'm going to be presenting on something. If you guys are having technical issues, do you want me to go?
Oh,
Doesn't matter. Or do you guys see the slides now? You see coffee in cases, young stroke, a picture of a coffee mug, anyone?
It
can't see
was
anything.
up briefly and it disappeared.
Okay.
okay.
Okay. Maybe just give us one more second. If not, that's a great idea.
Okay. Just a second here. I am gonna go like this. And I'm gonna share. All right, is it working now?
I can see the slides.
Yay!
Excellent.
Coffee and Cases family is affirming that they're seeing it.
Excellent.
Thank you,
It's
family.
it's a holiday miracle. All right. Hi, guys. Like I said, I'm Rick Raymond, one of the stroke docs here. It is Viewers Choice Month, and a lot of people wanted to learn about young stroke. So using the case-based format, ideally, we'll kind of talk about maybe 3 cases that highlight, I guess, the broad mechanisms that encompass young stroke. Just give me a second here. There we go. Nothing to disclose. No one's paying me to give this talk. We're going to talk about definitions, epidemiology, then the cases. We'll dive into the cases. So when we talk about young stroke, it's kind of a broad term. If you look at ages, it's kind of like 18 to 50 or 55. That's a pretty broad age range. People who are 18, they probably have mechanisms that overlap pediatric stroke. People who are 55, a large number, but not all, overlap what we can traditionally think of as kind of traditional risk factors and mechanisms of strokes. But in between people with young stroke in that age range, the number of types of mechanisms are much, much more broader than what we can think of stroke in adults over the age of 55. And that's most of them there too. The incidence or the number of strokes seems to be increasing from like 1980 to 2010. And that's probably twofold at the very least. One is we're getting better at diagnosing stroke. We're using more MRIs. So before somebody would have some symptoms and they'd say, it's probably a migraine. Now they might get an MRI and go, oh, actually that was a stroke. So we're actually diagnosing better. And number 2, the actual like standard modifiable risk factors. So obesity, hypertension, smoking, all those things are kind of increasing too. There are other things like infections, exposure to pollution too, to other areas of the world that also affect stroke. So it's on the rise a bit, still not as common as older individuals, but we see it. And we look at this graph here, we can see with each kind of age group, the risk kind of goes up exponentially. There's still stroke in the 20 to 39 and 40 to 59s. It's much less than the 60-year-olds. And if you look at the bar graph too, with red being women, we actually see an increased risk of stroke in females aged 20 to 39 and 40 to 59. And a lot of that is thought due to kind of being kind of pregnancy, around pregnancy increases the risk of stroke, both ischemic and hemorrhagic. Being on birth control or hormone replacement therapy, if it's estrogen containing at high doses, also increases it too, and kind of the postpartum period as well too. After that, we see kind of more in men, but kind of peri-pregnancy can actually increase your risk a fair bit. We'll start with cases here now. So case 1, we have a 35-year-old female, a 3-minute episode of right-sided transient monocular visual loss. All of a sudden, it kind of went black, gray, negative symptoms, and then resolved on its own. Prior to this, the weeks leading up to it, like probably many people on the call, maybe a little bit of cough, a lot of coughing, and then developed some right-sided neck pain. She's healthy. She takes some vitamin D, maybe just slightly hypertensive, but she's in the hospital there. And on exam, she has a right corner syndrome. What I mean about that is we see here, we see the droopy eyelid, the ptosis, the partial ptosis, and the small pupil, which is the miosis. So Horner syndrome there. He also gets a scan of the head, and the plain scan of the head is good. But if we look to the CT angiogram, which is kind of that kind of bifurcation there, if I use my little pointer here, can we see this? Let's go. laser pointer. You guys see that? See this here? So this is your common carotid. This is the external carotid that goes to the face. And this is the internal carotid that goes to the brain. But this kind of, whoop, it kind of tapers almost. Historically, that was called flame shape, but it kind of tapers right there at that point. So based on this, coughing, neck pain, Horner syndrome, tapered carotid, does anybody have an idea what the underlying mechanism might be? Feel free to put it in the chat. Screaming out loud with your microphone on or off, it's okay. I know a lot of people. Well, Ruth.
Oh, wait, Sarah Marshall, we see you.
Dissection. That is wrong. No, that is right. That is right, Cheryl Marshall. Thank you. Yeah. So carotid dissection. So when we look at dissections, carotid dissection is actually one of the most common causes, and some people say the most common cause of stroke in young adults. It's due to a tear within the internal kind of membrane within the carotid artery, and then blood goes behind it and kind of dissects the way up. So you have these two lumens, a true lumen and this false lumen. But in the false lumen, blood can go in there, it can thrombose and compress the true lumen. Clot can form at the area of the tear, and that can break off and go up and cause strokes. Carotid arteries are most commonly involved, but sometimes you can get the vertebral arteries as well. And if you look at the literature, it's about 50-50 in regards to traumatic versus spontaneous. So traumatic is pretty easy. I've seen people get hockey sticks to the neck and then they tear it. People in car accidents. However, like lots of sneezing can do it. Sometimes there's case reports doing loop-to-loops and roller coasters. But every once in a while, people just get dissections. And despite all the questions we ask them, they have no real kind of head injury or acceleration, deacceleration injury of their head at that point. The presentation is broad. A lot of times people get neck pain or like face pain, retroorbital pain because of that tear in the artery. Because the blood flow has changed, they can get pulsatile tinnitus, which is like hearing kind of basically your heartbeat in the ear. Amaurosis fugax, that's that transient monocular visual loss. That's usually because a clot is thrown up to the retinal artery behind the eye, or basically that eye is not getting enough perfusion because basically that lumen's being obliterated there too. People can get strokes and TIAs because they're throwing up clots. And then people can also get that Horner syndrome or that oculosympathetic palsy. So our sympathetic tract kind of starts at the back of the brain, goes down the spinal cord, over the lung, and then it wraps up the carotid before it goes to the eye. So if something happens to that carotid, if it expands and stuff, it can pinch that off, and people can have that Horner's, the ptosis, and the meiosis. The treatment to prevent further strokes, usually some kind of antiplatelet. There's some evidence now that a short course of anticoagulation, so that'd be warfarin classically or with a DOAC, can be beneficial to prevent further strokes. Luckily, if you've had a carotid dissection, the risk of stroke is actually front-loaded within the first 10 to 14 days. And then afterwards, the chance of stroke after that is actually quite low. If somebody presents with disabling stroke symptoms and they're candidates for thrombolysis, they can get thrombolysis. It's not a contraindication. And if somebody has a big clot that was thrown off and causes a large vessel occlusion, they're also a candidate for mechanical thrombectomy. In a lot of cases too, they'll get a carotid stent to pop open that thrombotic or that stenosed dissected vessel. So that's case number one, common presentation there. For her neck pain resolved in about 2 weeks. However, that Horner system persisted, and that's pretty common. People would have that Horner's, they had a little bit of a ptosis. For her, we treated her DAP for about 3 months, and we stepped her down to aspirin monotherapy. That means 1 aspirin a day. If you look at the American guidelines, they say you just really need 6 months of aspirin. That's all the data we have. We don't know if more is better because the chance of stroke after that is low. A lot of times we suggest probably being on an aspirin is okay, but we're kind of just extrapolating into the future. Because she had this dissection, sometimes we send off genetics for connective tissue disorders, and for her case, it came back as negative. So case number 2, 27-year-old male presented with sudden onset slurred speech and right-handed dysfunction. The symptoms started, he was lifting a heavy barrel. What was in the barrel, I don't know, but he was lifting a heavy barrel. Symptoms started after that. He has a little asthma. He uses a puffer. He doesn't do any of the smoking, the illicit or illicit drugs. Again, he's a little bit hypertensive, mild dysarthria, mild facial droop, and just a little bit of a pronator drift. So his NIH stroke scale is 3. So usually with that, he would not be a candidate for thrombolysis, even if he presented early. CT head, again, CT head's early. The symptoms are mild. Don't see anything on CT head. That's pretty common if they present early. And CT angiogram just shows we don't show any large vessel occlusion. So anything that's a smaller vessel, deeper vessel, something, the resolution of CTA just doesn't pick it up. And that's common too sometimes. So we work him up. Why is this 27-year-old having a stroke? We look at his heart rhythm with a Holter monitor. It's beating normally, no atrial fibrillation. We look at his sugars and his cholesterol. Both of them aren't really elevated. Same too, we look at the structure of the heart. Structurally, the heart's normal, but they find this big shunt from left to right going on at rest and with Valsalva. When they bear down and increase intrathoracic pressure, they see more of it. And with that too, a thrombophilia screen looking for clotting was negative. So with the shunting, we suspect that there's a PFO. And what that stands for is a patent foramen ovale. We all have little holes in our heart between our right and left atrium when we're in the womb, because we don't breathe in the womb. We're surrounded by amniotic fluid, right? So we have that oxygenated blood coming from the umbilical cord, going in, goes up, and just crosses across, so it can go to our body. When baby's born, baby takes a breath, that hole shuts. It's a little flap, and it shuts. It shuts in 80% of people, meaning 20% of people remains open, meaning there's over 1 billion people on the planet who have a PFO. And a vast majority of the time, it does not cause problems. But sometimes, in a very highly selected population, it can cause problems. It can be a source of stroke, or if a little clot forms in a vein, it can travel up. And instead of getting stuck in your lungs that act like a big filter, it crosses over and then can fire up as a stroke. So that highly selected population, they need to have stroke. These are from the studies that show benefits. It needs to be stroke. It needs to look embolic, so it's not a small vessel, kind of lacunar type stroke, right? They've had a big stroke workup, and we don't find dissections or webs or anything else. They're not forming clots anyplace else. And the PFO needs to have some high risk features. So it's a big shunt. We do that by the amount of bubbles crossing, so lots of bubbles. And if there's an atrial septal defect, which is a congenital heart disease, which is essentially a bigger hole associated with it. And we look for this because we know if people have a stroke that looks like this, no other cause, if we get that whole PFO closed by cardiology, percutaneously, so through kind of the wrists, if they do that and they stay on aspirin, the chance of recurrent stroke decreases over time. The rate of recurrent stroke with PFOs is actually low. It's only about 1% per year. But if you're 27, every year kind of adds up. So by 37, that's 10 years, you're still young, that risk is about 10%. But if you close the PFO, keep them on an aspirin, that risk is much, much lower. So his motor symptoms resolved in about 2 weeks, right? He had a follow-up. His NIH stroke scale was 0, which is good. However, he did have persistent fatigue that lasted up to 3 months, and this impacted his ability to return to work, really engage in life. And this might be a common theme that a lot of our kind of follow-up measures are based on motor ability, like walking, talking, but there's a lot of invisible symptoms, fatigue, cognition, etc., that can impact people's life. And then 6 months later, he underwent a PFO closure. Again, it's not emergent, so getting it in 3 to 6 months is quite reasonable, because the rate of recurrent stroke is only 1% per year. Case 3, last case. 41-year-old female presents with sudden onset diplopia, so double vision, and mild right-sided weakness. She had previous unprovoked DVT about 10, 15 years ago, and recurrent miscarriages. She was on blood thinner in the past, but not anymore. She's on some vitamin D, and she enjoys the occasional cigarette after her meals. Again, a little hypertensive when she comes in, but most stroke patients are. She has a complete leftosis. Her left eye is down and out, and then she has mild right facial droop, mild slurred speech, and a little mild pronator drift. So with that, it's an NIH of 4 kind of thing. So again, with this, you get a CT head. We see this hypodensity within the midbrain there. So I put this picture here. We won't go into the details, but at the back of the midbrain here is cranial nerve 3 nucleus, and the fascicle actually shoots up and runs out the front here. And this cerebral peduncle here is where our kind of motor tracts are. So if we get a stroke up here, we can get contralateral weakness, so weakness on the right, but also what looks like a third nerve palsy. So again, pointing to the brainstem as the area of stroke. So we get these brainstem symptoms. That looks like a third nerve palsy plus contralateral weakness. So pretty classic midbrain presentation. Her Holter was negative. We did the echocardiogram. That was completely negative. Doesn't have diabetes. Doesn't have dyslipidemia. We do a broader workup looking for underlying thrombophilias, genetic or otherwise. And actually, her antiphospholipid antibody screening was positive. So her lupus anticoagulant was positive. Her anticardiolipins was positive, but beta-2 glycoprotein was negative. So again, with this history of recurrent miscarriages, unprovoked venous event, and now arterial event, we're really thinking about antiphospholipid antibody syndrome, or sometimes people call it APLAS. So it's an acquired thrombophilia caused by antibodies against the cell membranes. People can get venous, so clots in the veins, but also clots in the arteries as well too. And there's a lot of pregnancy complications, so miscarriages, stillbirths, and even preeclampsia, there can be association with it. Sometimes it's primary, it's by itself, but about 30% of the time, it can be associated with connective tissue disorders, specifically lupus. Diagnosis, there's laboratory criteria and there's clinical criteria. So laboratory, you need one of three, or you can get more of those kind of lupus anticoagulants. So lupus anticoagulant, anticardiolipin at high titers, or beta-2 glycoprotein at high titers. Essentially, you need them positive on 2 occasions, 12 weeks apart. So sometimes if you get it once, we're still repeating it 3 months later to make sure it remains positive, because it's not uncommon. It'll be positive initially, especially if a stroke or a thrombotic event happened and it goes down. So you need one of those, at least one, 12 weeks apart. But the more you have, if you're double positive or triple positive as opposed to single positive, your risk for thrombotic events goes up. So if you're double positive more than single and triple more than double. Clinical criteria is you need confirmed venous or arterial thrombotic events. Our lady had DVTs. She also had this stroke, which is an arterial event. And then the obstetrical complications is pregnancy losses, spontaneous abortions, et cetera. And she had previous miscarriages as well. So the reason why we look for this is it kind of changes management as well. So basically, she was initially started on dual antiplatelet therapy, like a lot of people do for a minor stroke. But as her investigations came back and after we repeated them, we actually changed her to oral anticoagulation. And most of the literature supports warfarin, a dose-adjusted warfarin for this, especially for double positive or higher at that point too. She was also referred to hematology. Because of the diplopia, remember she had the diplopia, she looked like she had a third nerve palsy. She was referred to the post-stroke visual impairment clinic, that's at Saskatoon City Hospital. And eventually they followed her. And then when they felt that recovery was complete, they actually put prisms, actual prisms in her glasses to help with the diplopia. She had ongoing fatigue and has developed intermittent headaches post-stroke, even though she's walking and talking a bit more, still having the diplopia, still having some post-stroke complications. So overall, stroke is less common in the young than people over the age of 55. And the causes of stroke in the young people are much, much broader. So we have to put on our thinking hats and really dive into it. So it requires a thorough clinical assessment, and usually our workups are much broader. And like I said before, the overall numbers of stroke in young people are increasing. We're getting better at diagnosing it, but also risk factors are increasing it. Even though the etiologies are broad, modifiable vascular risk factors are actually quite common. The most top 4 being abdominal obesity, tobacco smoking, physical inactivity, and hypertension. We also see some cases dyslipidemia. We also see excessive alcohol use can increase your risk of stroke, and even illicit drug use as well too. Things like atrial fibrillation happen, but they're much less common. But if somebody has it, it's still a high risk factor for stroke. The mechanisms for stroke fall within the big categories. So like I call the pump, the pipes, or the blood kind of thing. So the heart, but instead of looking for things like atrial fibrillation, which are much less common, we look for things like PFO, congenital heart disease, even infections like infective endocarditis. For the large artery causes, like looking at the pipes, instead of looking for atherosclerotic disease or carotid stenosis, we're looking for dissections, carotid webs, and Moyamoya syndrome, which is a non-inflammatory, non-atherosclerotic disease of the terminal ICAs where they get stenotic over time and develop these kind of collateral blood vessels. For small vessel disease, we're not looking at standard lacunar strokes due to hypertension, diabetes for a vast majority of people. These are due to monogenetic causes. So people who have CADASIL, carousel, these are genetic disorders that can cause stroke plus other neurological symptoms. And for underlying clotting diatheses or prone to clotting, we're looking at things like antiphospholipid antibody syndromes. There might be some genetic thrombophilias in there too, but also sickle cell disease, we don't see a lot of it here, but down south we see more of it there, which can cause stroke. And even kind of underlying malignancies, sometimes the first presenting feature is stroke, and then you find the malignancy afterwards. In general, the outcomes tend to be more favorable in young strokes compared to elderly adults. A lot of that is due to the fact that younger people tend to have fewer comorbidities to deal with. However, the outcome measures, like I mentioned before, that we use for to see how people are doing, like the modified Rankin scale, that's really heavy on kind of walking and mobility, right? However, people can have a lot of invisible symptoms after stroke, so like headache, cognition fatigue that can impact your ability to go back to work, impact your ability to kind of care for your family, do your hobbies. So because of that, a lot of physicians and researchers, Ruth Whalen being one of them, I've tried to come up with different outcome scores to get a better idea how people come. So there's the Cosmo score, the Canadian Outcome Scale for minor stroke. Again, this is minor stroke. It's a 0 to 6 point score to see how people are doing. So somebody who'd be an MRS of 1 might be an MRS of Cosmos of 3. So getting a better idea of outcome in young stroke. So probably as time goes on, we'll be using things like Cosmos or other things to get a truer picture about how people are doing outcome-wise, because you might be walking, talking, feeding yourself, but if you're not going back to work full time or not caring for your family full time or pursuing your hobby like Duolingo full time, it is impacting your life a bit. But I'll stop there. That was kind of a broad overview, hopefully illustrated by some cases. But we can answer questions now, or we can save them to the end. I don't know what we'll ask our producer.
Probably have 4 minutes.
We have 4 minutes for questions.
So I did put a question in the chat.
Question in the chat.
So I put a poll
Okay.
that said, how long until someone can return to regular activity like sex, exercise, travel?
Yeah.
And I put a couple options in there.
Okay.
So people, let me just look at the poll results. Oh, can you see it on yours? It's not working on mine now. Goodness gracious. So I think I had 1 year, 3 months, 6 months, no restrictions, and it depends on what caused the stroke.
What did people say? Or are you just asking me?
Well, I put it in there.
Okay.
Most people said that it depends on where the stroke, or what caused the stroke.
Yeah, I think that's fair. And I think we have a physiatrist here who's going to know much more than I, right? Probably gets to ask that question. But when somebody has a stroke, one concern is stroke reoccurrence. The highest risk of recurrence happens within the first 90 days. And actually, most of that is front loaded within the first 2 weeks, 2 days, right? So after the 3-month window, if people are on right medication, the chance of recurrent stroke in general is much lower than opposed to day 1 or day 2. However, the etiology plays a role. So large artery disease, like tight arteries, I'm talking more about older people now, that tends to have a higher recurrence of stroke, so it might be slightly higher risk. That being said, I think return to activity depends on a person's abilities, right? I think, and well, I'll defer to our physiatry colleague here a bit too. So sometimes if people are like, can I get back to walking? And I'm like, absolutely, you can get back to walking as long as it's safe if they can walk, right? At that point. And travel is another thing too. I think SGI might have some guidelines there. Usually SGI says no driving for at least 1 month after a stroke. If you have visual problems, visual spatial, it might be longer. But I kind of abide by that. But after that, if people have no visual problems or motor problems that impact their driving, getting back to driving is more than reasonable at 1 month. And flying too, usually being in an airplane does not increase your risk for stroke. However, I just tell people, like, you know, if you have a stroke in another country, that can have significant insurance implications. So keep that in mind and maybe get some good insurance. And then maybe wait for those 3 months because your chance of recurrent stroke on good medication is much, much lower. But I will now take a step back to see what others have to say.
Okay, well, think about questions in the meantime, but I think we will move on to Renelle, who is one of the physiatrists that work here at Saskatoon City Hospital and comes over to RUH to assess our patients for rehab, which we are so grateful for her expertise. I don't know, like physiatry, a lot of people don't know what a physiatrist is, but I think we've already had one physiatry resident, so you guys will certainly all know what physiatry is, but I'm going to introduce you, Renelle. So Renelle was born in Saskatoon, Saskatchewan. She completed her medical school at the U of S in 2017 before she moved to Hamilton, Ontario, to complete her residency training in physical medicine and rehabilitation at McMaster University. She joined the Department of Physical Medicine and Rehabilitation at the University of Saskatchewan in 2022 and as the clinical lead for acquired brain injury. Her interests outside of medicine include Nova Scotia duck trolling retrievers. That's a mouthful.
Questions about that?
Yeah. Sports and spending time with her 1-year-old daughter and husband. So she's not quite driving that little 1-year-old
Just wait for it. Just
around.
wait
It's
for it.
coming. It's coming for you. So, like, Renelle, thank you so much for being with us. We can't wait to hear what you have to share. And we can see your slides, but you are muted still.
Sorry, I realized I have to unmute myself and then share because I couldn't find the mute button after I shared my screen and it went to my PowerPoint.
You know what? I probably could have
There we
unmuted you too.
go. Nova Scotia duck-tooling retrievers are a type of dog from Nova Scotia, and I have one, so I'm kind of obsessed with her. Bit of a niche dog breed for dog nerds, but ask me about it sometime. I'll tell you all about it. So I was going to talk just a little bit about what some of the rehabilitation issues can be. So you have to forgive me. This is my very first coffee and cases. So I didn't, maybe the name should have clued me in that like maybe a case-based format. I didn't think about that. So we're mostly just going to be talking, but it's pretty casual. If you have questions, let me know as we go along. So young adults with stroke. This isn't as common as seeing older folks with stroke, but it certainly happens. And as Dr. Graham kind of touched on, in general, the recovery and the prognosis are better for folks who have had a stroke when they're young versus when they're older. And overall, when we're looking at sort of our rehabilitation techniques and what we're actually doing for rehab, it's not overly different what we're doing for young people versus old people, but it's more just their societal context. The things that are a focus or a concern for a young person is not necessarily the same as what somebody who's older is concerned about with their life. There's often more issues around work, having dependents, that societal expectation of, a young person and their health, and also just if there is disability, the fact that they're living longer with disability and going through that aging process with disability someday. So it's not so much that what we're doing is so different, it's just the context is really different for these individuals. So I thought we'd talk a little bit about some of the issues that come up more often for young folks. But again, these aren't exclusive. Like this could be an issue for an older person too. So often something that does come up is this return to work and to school. And often at first, after someone has had a stroke, they're really focused on their recovery and regaining whatever function they might have lost from that stroke. But at some point, this starts to transition more to a return to life, and that means often a return to work and school. And sometimes that's even sooner than somebody might want because of the financial constraints that they could have. And so it's just something to keep in mind that anytime that we can support somebody financially by helping them with disability support programs, working with them on employment insurance, that's something that can be really helpful for them so that it gives them that opportunity to focus on their recovery early and not feel that pressure to immediately get back into work. But in terms of sort of that return to work, it's always very, like anything in rehab, very individualized. It depends a lot on what type of work they were doing or type of school they were doing. So a job that's very physical, say you're working in construction, is going to be very different than, say, the type of skill set you need to return to work as a lawyer. So you're looking at what type of work they're doing and then also seeing how their impairments from their stroke might impact on their work. So sometimes that's the specific neuro impairments they might have, whether that's physical, cognitive, or communication. And sometimes it's just, like you mentioned, Dr. Graham, that general sense of fatigue, and that's very prevalent. And as a new, well, can I still say I'm a new mom? As a newish mom, I can attest to fatigue as being a real thing. So that's something that, is a really quite a silent symptom that we have to be mindful of. So in general, there's lots of ways that we can support people in a return to work. And often with our team, it might be the physician or the physiatrist helping, but often it's our occupational therapists who are looking at this. Sometimes it's specific vocational counselors that are working with somebody to figure out what they need to be able to do to return to their job or a different job. And sometimes it's our colleagues in the ABI outreach program who are helping with this. So there's lots of team members that might get involved. A unique thing that we sometimes see is when somebody has a very high level cognitive job, and you want to make sure that, as a more invisible deficit sometimes, that, they're really able to do that type of work again. And so we can involve kind of our colleagues in neuropsychology who are able to do really detailed and focused assessment on different areas of cognition. And when I'm talking to people about this, I kind of present it more as this is a way to understand your thinking and how your brain works so that we can find your strengths, so that we can really use those strengths to compensate for any weaknesses you might have in getting back to the things you want to do. So often when we're looking at these kind of more intensive assessments, it's because we really find that the outcome of those assessments really directly impacts how somebody might return to work or school or give them the strategies to be successful. So that's one of the things that we're kind of looking at that's maybe a little bit different for the young person than an older person who's had a stroke. The next thing I wanted to talk about is intimacy and sexual activity. And again, this is not just something for young people. We should really be talking about this with all people who have had a stroke, because half of all stroke survivors will experience some form of sexual dysfunction. But this is maybe one area where young people are at a bit of an advantage in that healthcare providers are actually a little bit more likely to talk to somebody who's young than somebody who's old about this as something that can be affected by stroke. And you can see here, I've pulled out this chart from a recent review on sexual dysfunction after a stroke about all the different barriers that we might have for talking to our patients about this. I would say a big one is that, the patients think that the doctor should bring it up, and the doctor or the healthcare provider thinks, well, the patient will ask if they want to know. But usually that just means that it doesn't get talked about. And one of the big things that I find, and for me, I've always found that it's not a discomfort talking about sexuality or intimacy. It's that I don't know what to say, and I want to give them information that's good. And that's difficult because there's not a lot of information out there. And again, I went to look at this because we were going to be talking about this today. And, you try to find something, you're putting it into Google, and even AI can't really help you out with this, is when is it safe? And you're looking for, an answer. I want to know when is it safe for my patient to return to sexual activity? And that's a big question for patients and also partners who can be concerned about, not wanting to hurt their partner in this. So is it safe? Generally, yes. So kind of two areas where you might be thinking about it a little bit more of, taking a little bit more time to return into sexual activity is if they have very uncontrolled hypertension, because sex is basically exercise. And with exercise, your blood pressure and your heart rate are going to go up. So for most people, that is not going to be a big problem. But, the person who's just recently, within the last 2 weeks had a hemorrhagic stroke and their blood pressure is still, 180 on 100, you might be thinking, that's not the person I'd send to the gym to go exercise. So maybe they should be a little bit cautious about the physical activity piece of sexual activity. It's about as much exertion as going up 2 flights of stairs, those to give you sort of some context around that. Sometimes too with the surgery, you want to make sure that it's not going to compromise any of kind of the tissue healing or the surgery there. So that might be a situation where they're looking for specific guidance from that surgeon. But in general, for most people, it is safe. And whether we talk about it or not, they're going to go back and do it. So we might well talk about it. My general advice is that they should go slow and listen to their body when they're getting back into sexual activity. And so it might mean a little bit more communication with their partner about that piece. But, listening to your body is the number one key. But there's lots of other barriers to returning to sexual activity or intimacy. There's lots of feelings of loss of energy or desire. That fatigue piece is really prominent. There can be medication side effects. So some of the things that we prescribe, like a common one would be SSRIs that might be prescribed in the setting of kind of a mood disorder, can really impact on kind of that sexual desire, but also things like orgasm or the ability to maintain an erection. So these things really do impact people. And even something common like our hypertensive or antihypertensive medications can affect this. So these are all things that somebody can be dealing with in the context of stroke. A really big one is this change in relationship. Some people are dealing with, more that caregiver role versus what was more perhaps viewed as an equal partnership before. So these are kind of things that, are really important for partners to work through. And then we can't forget the impact of just impairments in terms of things like continence, physical positioning, and even with aphasia communication. So it's complex, but not talking about it doesn't help, because then people are just left on their own or using the internet. So some basic strategies when you do want to talk about this. One thing is to just make sure that it's a more private conversation if you can. Like, you're not trying to do this in the four-person bedroom when, 3 neighbors are keen to listen in. It's important to sort of ask permission. So just starting with, I ask everyone about returning to sexual activity or intimacy after a stroke. Is that something you're okay to talk about today? And so you want their permission to move forward with this topic, and then just moving from something general to more specific. So, you might just sort of ask how that relationship looks with a partner or with somebody, and they might give you some information, and then you would kind of go into something more specific based off of whatever they told you. So you might ask them how sexual activity is going for them after their stroke, and they might say, I have trouble with erectile dysfunction, or maintaining an erection. And that's when you would kind of take that and then work a little bit more on that specific issue. And then just always try to be neutral and validate and kind of make it as normal as you can to talk about these things. And then I thought these are some actual practical tips. So maybe you're talking to someone and you're like, well, now I'm talking about it, I don't really know what to tell them. So one thing to look at is kind of, if they've got a motor or sensory impairment, sometimes it's actually a matter of increasing the sensory stimulus is what helps somebody. So if they don't have a great feeling, in order to have kind of a feeling of sexual pleasure, they might be having to find ways to increase that sensory stimulus. If they have spasticity, maybe you're working on positioning that will work for them, or treating that spasticity with the goal of sexual activity, because we're always treating spasticity with a goal. Managing their fatigue, so finding, a good time of day, and even just bowel and bladder management. So, emptying the bladder before intercourse, for men, using a condom. These are some of the practical things that when you're talking to somebody about their problems, you might actually be able to give them some advice on how to manage these things. Of course, this isn't an exhaustive list, and it really is a very, as you can imagine, sort of personalized approach. And I would say that it's not covered, but if somebody is really struggling and wanting more, there are sexual health therapists that they can get in touch with, but it's not something that's covered through any public health plan. I'm not sure. I feel like most private health plans don't cover it, but maybe it could fall under counseling or some other kind of thing in their private plan. And then we kind of talked about this a little bit too, this return to driving. So again, anytime you've had a stroke, there's no driving for 30 days. And physicians and other healthcare providers, occupational therapists, nurse practitioners have a duty to report to SGI if there's any physical, sensory, or cognitive deficit as it relates to their stroke that could impact on driving. And as long as the underlying cause is addressed with appropriate treatment, and there is resolution or adaptation that's appropriate for that deficit, then they could return to driving. I mentioned this as like there's some specific requirements around if somebody's had a seizure after stroke, or if you have an untreated brain aneurysm, that would have there's some specific situations you have to be a little bit aware of. But usually what happens is if somebody has had a stroke and say they have some ongoing weakness on the right side of their body, you would report that to SGI using the supplementary medical application form. And usually what that means is the SGI medical review unit sees it and sends a letter to the patient saying, you need a further medical report completed before you can return to driving. Oftentimes, an occupational therapy is helping with some of the assessments for whether or not there's ongoing concern for driving, whether that's cognitive or physical. And sometimes just based, again, it's very individualized. They might need further evaluation that's more detailed in a place like the driver evaluation program at City Hospital, or the driver assessment program in Regina. and they would do more detailed sort of look at things and even look at adaptations to a vehicle. So this guy has some hand controls, and depending on the cases, SQI might even want an on-road driver's test. So it's very specific to the person, but it can feel like a lot of hoops to jump through, and driving is a sensitive topic to talk to people about, but it's often, you know, not just saying I have to tell STI about this, but giving them some sense of the support and what to expect next and how you're going to help them work through this. And then the last piece I kind of wanted to talk about was just this idea of parenting after a stroke, and that it's hard enough to parent without a stroke. Imagine having kind of that uncertainty and in some cases ongoing disability and the challenges somebody might face. So as much as they can, having and building that support network is important. But I kind of thought I'd touch on two sort of subtopics in this, the idea that there's lots of adaptive equipment that's out there now specific for parenting that you might not have even thought of that is out there that means that somebody can still successfully parent after a stroke. I picked out a few that I thought were interesting. So the idea of hands-free bottle holders for somebody who has a young child who's needing a bottle to feed. Using modified clothing, so things for children that are easy to get on and off, maybe things that don't have a lot of buttons or zippers, but thinking about that. Using grab bars in locations where you might need more support, so around the bathtub or a change table. There's lots of things out there, and again, it means being a little bit creative about some of the equipment that you might use to parent. And then also, again, fatigue. Fatigue is real. Probably all of us feel a little fatigue sometimes, but post-stroke fatigue can be very debilitating, and parental fatigue, I can assure you, is at times debilitating. So these were some practical strategies and tips that were offered around trying as much as possible to create routine, trying to schedule in those breaks. And sometimes that just makes it a little bit easier for your family or someone's family to understand that, you know, they're going to need a little bit of a break during the day, that they can't just go. And so trying to build that routine, trying to use a schedule, trying to prioritize those activities that you know are really important to you for a time of day when you have more energy. So you're not trying to set up a new toy doll house that's extremely complicated from IKEA at 10 p.m. Like, you know, that's going to be either a more cognitively challenging or fine motor challenging task. Do that when you have more energy. And then, of course, try and use as many supports as you have available. And don't be afraid to lean on those supports. So all of these things, I think, if there's a theme, it's that everyone's unique. And I think some of the needs for young people with stroke are different than what the concerns and focus are for an older individual with stroke. And it's just trying to figure out where they're at, what are their goals, and how you can help them to achieve these goals. So hopefully that gives you some food for thought. Okay, I'm gonna try and escape out of here. Perfect.
That was
I'm
really
sorry, I don't have a case. I'm trying
No,
to think of a case.
That's okay. If anyone has any questions, please, or comments or stories, please put them in the chat. Don't hold back. I really liked how you were talking about when you're doing more in-depth assessments, it's to pull out the strengths that people can use to get them back into the workplace. And like I've never said that to my patients, but I can imagine they just feel such hope when you find those key things that right now they can do, knowing that there's still other recovery to be made. Because I even think about when we affirm that our aphasic patients can understand more than they can say, just that it's like this magic that you've handed them that gives them back some control and power. So that's a really good takeaway. Comments?
Oh, that was great. Thank you. But because I like these coffs and cases for a lot of reasons. One is we get experts joining us here. But also when I did my fellowship 9 years ago, it was at a very high acuity, high volume center, acute stroke, right? Then people were discharged to rehab. We didn't have a lot of follow-up. We did work in the stroke prevention clinic. And then my first year of practice here, it was very humbling, but also a great learning experience because people's like, hey, it's a stroke doc, let's send them patients who've had strokes. And a lot of their questions, I'd be focusing on secondary stroke prevention and mechanism, which is important, but their complaints would be about recovery, fatigue, and driving and sex and all these things, stuff that I had no real training in. So I learned a lot that year. And then luckily after about 1 year in, a young Dr. Jing Shi joined the physiatry group in Saskatoon, who was a huge help and a great teacher and stuff, right? And now the physiatry group continues to expand as well too, right? Which is great because, like I said, when I see someone after they've had the stroke, after kind of the dust has settled a bit, a lot of it is about recovery and questions. So very important topics.
Yeah, that's a question.
Okay.
Questions are rolling in.
Does the risk of stroke become higher in women in that younger age range related to postpartum factors?
Yes. In general, the risk of stroke kind of increases kind of in pregnancy. It's usually kind of in the third trimester during the pregnancy itself, and like the postpartum period is like the first 6 to 12 months at that point. So there is a risk. People say it's up to 6 times increased risk. That risk is low to begin with, but there's a bump. The risk that's interesting is about 50% ischemic and 50% hemorrhagic, where usually in general we think ischemic to be 80% or the bulk. So there's a bump there too. People can even get venous complications like venous sinus thrombosis. And then later on, like taking increased doses of estrogen can increase your risk too at that time for some people. So pregnancy is a risk. I'm not saying don't get pregnant because of it. Please have your families, but it's something we have to watch out. So usually if I get a phone call about a pregnant female, like when I'm on call with some numbness or maybe even some headache and some subtle features, stuff that I would say normally I would think would be kind of low acuity, just given the fact that they're pregnant, I always make sure to come and see them even if it's overnight with the resident.
Another interesting thing that increases risk of stroke kind of postpartum, but longer term, is that these young moms who have had high blood pressure during pregnancy or diabetes, less gestational diabetes, get busy with these young families and probably aren't getting their physical exams, their yearly checks, and so grumble along with kind of persistent hypertension or actual diabetes and just kind of fall off the map a little bit. So another kind of interesting thing that we're seeing is younger people coming in and they're like, oh, I didn't know I had high blood pressure or diabetes, but yeah, I did have it when I was pregnant. So something for GPs to kind of have on the back of their plate.
Yeah. And even having, say, preeclampsia during pregnancy increases your risk in general, right, for cognition or stroke. So again, if you have patients like this who've had preeclampsia, again, monitoring them for blood pressure issues later on, or gestational hypertension or diabetes in general, they're at higher risk for having these later. So ongoing monitoring, hopefully with their primary care provider, to make sure that these are being treated adequately and they don't kind of sneak up in the background.
Did you want to touch on estrogen being protective?
Okay.
Until
or this one, does taking hormonal birth control pills increase the risk for stroke? So yes, in some fashion. So the estrogen-containing ones, as opposed to the progesterone, can increase your risk for thrombosis. It's dose dependent, so the bigger dose you're on, the higher the risk. So some pills just have just tiny little amounts. However, it is modified by lifestyle factors. So if you have a history of migraine with aura and you're on estrogen-containing birth control, your risk for a thrombotic event, including stroke, goes up a little bit. However, if you're migraine with aura, OCP with estrogen, and you smoke, higher, and as well too, goes a little bit higher as well too. So it kind of goes up. So it's kind of modified by a few things as well. So so it does. So usually we don't tell people don't take estrogen-containing birth control pills. However, if you've had a stroke and you're young, we felt that was a cause of maybe the thrombosis or playing a role in it, then kind of switching to something more progesterone-based, depending what the need is for, or maybe like a copper IUD might be better for contraceptive in the future.
How about testosterone? We have a lot of fellas coming in just not getting the pump they want at the gym. start taking the testosterone.
I'm unsure, actually, about the testosterone. Yeah, I am. I haven't heard. I don't know if I think I read a recent article that it doesn't. I could be wrong. Don't quote me. I will go to
Stay
the
tuned.
Google, the
Stay
Google
tuned.
machine, and then some kind of good database afterwards. I don't know. Somebody else might know about that one.
Interestingly, right now, without giving too much info away, we have 2 young strokes on the unit who both had an influenza-like illness in the not so recent past, and one from the coughing. We think's probably why this patient had dissection of their vertebral arteries, causing brainstem stroke, and the other one had a pneumonia, which made the patient hypercoagulable, also causing stroke. And we're talking young, like 20s, 30s. So just a little push to encourage your patients to get the flu shot to prevent stroke or as secondary stroke prevention. Brett, one thing I was wondering, like, I don't know if any of our peds people are around, but Mark has a good question, but how about kids and stroke? Are the etiologies, what's the most common etiology for a kid?
So with kids, it's probably between again, I'm not a pediatric neurologist, but a congenital heart disease, but also they can get these focal arteriopathies, which might be inflammatory. So you get like focal segments of inflammation that cause stenosis of larger arteries and kind of thrombosis as well too. And sometimes those are treated with kind of steroids for a short period of time as well.
And luckily the symptoms for stroke are pretty much the same in a kid as it would be in an adult with face, arm, speech. Okay.
How do you determine when it is safe for a weekend athlete to return to the gym after a dissection?
Yeah, it's a great question. There's no specific guidelines for this. However, kind of stemming from what I said before, the risk of stroke after dissection is highest within the first 10 to 14 days. So nothing before that. A lot of the time we're re-imaging people again at about 3 months to see if things have resolved. And even if you look at American guidelines, some people we can stop antiplatelet therapy maybe at 6 months. So I'd probably tell someone nothing for the first 2 weeks, maybe light activity for the first 3 months. And then after that, kind of what Dr. Calver said, listen to your body, kind of moving forward. Again, that's because my, off the cuff general advice, but that's the way I'd approach it, I think.
Okay.
About 3 minutes.
You have something you want to share there, or?
Oh yeah, geez, you guys, brother. So there is a couple of really good resources. Number one, if I haven't sold you, you can't really see it.
Here, do you want me to show it online?
Here, sure. On the Your Stroke Journey, free resource from Heart and Stroke. Ashley is gonna, in our next letter out, email out, she'll put the link for how you order Heart and Stroke resources. They're free. They're great. I left a whole box in Yorkton last time I went, and I hope you're running out because you're handing them out. But you can also, in the interim, before you order it, you can just print off colored or black and white or colored PDFs. And there's some really great stuff in here for living with physical change. There's some of the highlights that Renelle, you covered on bladder and bowel, on relationships and sex, on returning to work, and a few different kind of national supports that you can go to for that kind of stuff. And then there is also on Heart and Stroke website, you can't order it, you have to print this one off, but stroke in young adults. And to tell you the truth, this isn't my favorite resource, but it is another resource for your patients that kind of, again, covers like, is it normal that I feel tired? When can I go back to school? When can I go back to work? So a couple of nice resources. And the other thing, I don't know if Ashley put it in a poll, but how many people have heard of the acquired?
Most people have.
Oh, most people have.
Yeah.
So the ABI outreach team.
87% said yes.
Good. Good. You guys use that group. They are so good. Like you hear about kind of March of Dimes and stuff being a really good resource in Ontario and BC. ABI is kind of like our March of Dimes. I don't know who just celebrated. Maybe it's an ABI person. we want to have you on Coffee Cases to tell us what you guys do, but they just are such a good resource connecting patients, following patients, helping arrange stuff for patients. This is a great option for our patients going home. Okay, it's 4 o'clock. Workday's done. You guys, Merry Christmas.
Happy Hanukkah,
Happy Kwanzaa.
happy Kwanzaa, happy holidays.
Happy holidays.
Where's your Spanish?
Hola. Feliz
Feliz
Navidad.
Navidad. We will see you in the new year in January. January topic. We're bracing ourselves for that Blue Monday when we get our visa bill in January, and it's going to be all about mental health.
Blood pressure rising,
Both our mental health
mood lowering.
as well as our patients' mental health post-stroke. So please come. We will love to have you back. Okay? See you guys next time.
Thanks, everybody.
Remember to save lives.
And improve functional outcomes.
And Renelle, thank you.
Thank you.
Thank you for your first Coughing Cases. You did great.
First but not last.
First but not last, a real champ.
You know, I think I'll be back. I'll see you. I'll see you in January.
Bring your friends. Rochelle, I wonder if that's Rochelle Goodkey.